everyone, I'm Rashmi Mabiyan Kaur, Senior Correspondent at ETHealthworld.com, welcoming you today's webinar on the topic Do's and Don'ts for Good Pancreatic Health. As we are aware that pancreas is one of the most crucial organs in digestive system. It releases enzymes that helps you to digest by breaking down the foods and regulate blood sugar levels. In this webinar, we look to explore how one's food and lifestyle habits impact the pancreas as much as your digestive system. The experts in the next 60 minutes will dwell into the do's and don'ts of right pancreatic health. To take forward this crucial discussion on how lifestyle impacts the pancreas, please join me in welcoming our panelists, starting with Dr. Avinash B, Consultant Gastroenterologist, Head of Department, Ramaiah Memorial Hospital, Bangalore.
Thank you, madam, and good afternoon, everyone.
Dr. Parimal Lawate, Director, Department of Gastroenterology and Liver Disease, Jehangir Hospital, Pune.
Thank you very much.
Dr. Piyush Ranjan, Senior Consultant and Vice Chairman, Department of Gastroenterology, Sir Ganga Hospital, Delhi. Dr. Sanjay Kumar Banerjee, Consultant Gastroenterologist and Hepatologist, ILS Hospital, Kolkata.
Hello and good afternoon to everyone.
Dr. SK Sinha, Professor, Department of Gastroenterology, PGIMER, Chandigarh.
Hello, everyone.
And Dr. M Hariharan, Senior Consultant Gastroenterologist, Apollo Hospitals, Chennai. Thank you so much for joining us today. So let us now begin with this crucial discussion that covers pancreatic health. I'd like to start with Dr. Sanjay. Could you tell us the role of pancreas and how important it is for the pancreatic health in an individual?
Good afternoon, everybody. And this is a very good question. This is a basic question to start with the discussion on pancreas. Pancreas is a very vital organ. It's situated inside the abdomen, behind the stomach, and in front of the spine. The pancreas essentially serves two functions. One is exocrine function, where it produces enzymes which help in digestion of carbohydrate, protein, and fats. And another is endocrine part, where it produces hormones which are transported by the blood. Hormones are mostly insulin, and it's a counter hormone glucagon, which act on different organs of the body, and essentially they control the blood sugar. So this is an organ as well as this is a gland, which serves two important functions. One is digestion, and another is control of several metabolic parameters in the body through the modulation of insulin and glucose homeostasis. Thereby, an organ which serves two distinct group of functions is very important for our health, and we need to protect it, and we need to keep our pancreas very healthy.
What are the factors that actually damage the pancreas?
There are many factors actually. The most important and most notable is alcohol, because worldwide the commonest cause and most important cause of any form of pancreatic injury is alcohol and smoking. Individually or separately, alcoholism and smoking are important risk factors, and in combination, they are a double whammy. So apart from this, pancreas would be damaged by excess of triglyceride in the blood, excess of calcium in the blood. It could be damaged by several viral infections. It could be damaged by intake of certain drugs. And some of these drugs are quite common in our day-to-day practice, like thiazide diuretics, like steroid, like aminosalicylates, which what we use to treat colitis. And there are many similar and common drugs which are implicated in the causation of pancreatitis. Apart from this, in childhood, trauma to the abdomen is an important cause of pancreatitis. And even in the infant, there is a genetic disorder called cystic fibrosis, which is an important cause, particularly in the Western countries, as a cause of pancreatitis. Most of these diseases or conditions what I described are cause of acute pancreatitis, and alcohol is an important cause of chronic pancreatitis, though most of my colleagues will agree that some cases of acute might progress on to develop chronic pancreatitis.
So, Dr. Avinash, what are the signs and symptoms that indicate a poor state of pancreas?
Yeah, thank you for the opportunity as well as the question. So like the poor state of pancreas, generally we classify it as whether it is acute pancreatitis, where the earlier patient is completely asymptomatic, and they tend to have upper abdominal pain, which might be going to the back, and there might be associated with vomiting. and there might be not passing stools, like what we call it as constipation. And depending upon the what caused the pancreatitis, like some people, there might be a history of trauma to the abdomen, or there might be a gallstone which might have caused pancreatitis. There might be concomitant yellowish discoloration of eyes and urine. So predominantly, these are all the features of acute pancreatitis. In chronic pancreatitis, where the disease has relatively progressed and the gland has fibrosed and poor functioning of the pancreas, they tend to have, again, dull aching abdominal pain. They may have, as Sir has already mentioned, they may have exocrine insufficiency, where they may have indigestion of food with passing of greasy and oily stools, what we call it as steatorrhea, where fat is not getting absorbed. And they may tend to have weight loss, like a significant weight loss. These are all because of the indigestion of the food material. Coming to the endocrine part, that is the organ or the glandular part, so where people tend to develop diabetes mellitus, like where the sugar can fluctuate. So what we call it as brittle diabetes, like little more of the insulin, the sugar can come down, or little less of insulin, the sugar can be relatively very high. So these are all the majority of the signs of or symptoms of acute and chronic pancreatitis. Coming to the signs, what we generally see is whether history, like looking wise, any jaundice is there, any discoloration of the abdomen skin is there, like auscultation wise, the bowel sounds are there or reduced. Depending upon that, we categorize an acute abdomen patient into acute pancreatitis or chronic pancreatitis. Signs are predominantly used for clinical diagnosis. Symptoms we should be very much focused upon.
And what should be the ideal choices for ensuring healthy pancreas, according to you?
Yeah, so like most important thing is the don'ts are like definitely no smoking and alcohol, because these are all the two triggering factors for pancreatitis. Second thing is, rather than binging on 3 fatty meals, it is always better to eat small frequent feeds similar to the any diabetic diet that we generally tell. Less of carbohydrate and less of fat, predominantly processed fat like cheese or higher calorie substances, whereas the proteins are relatively safe. So like, because oil and alcohol, these are the two triggering factors for pancreatitis. And most importantly, like we should avoid, again, like whenever a particular person is having hypercholesteremia or cholesterol levels are very high in the families, and also they tend to do regular physical exercise. So which is along with the diet, which is very important.
Okay, so coming to you, Dr. Parimal, what are the different types of diseases associated with pancreas?
So I think, like it has already been discussed, there are many diseases which can affect the pancreas. You can start with very small children, where there can be hereditary disorders, like it was mentioned by Dr. Piyush about cystic fibrosis. Then there can be some cases where there's hereditary pancreatitis. So there's one family member who has pancreatitis, and there are several other members who also have pancreatitis. So there you have a family history of pancreatitis. So these are called as congenital or hereditary disorders, which have some genetic transmission. The second group of disorders actually is pancreatitis, which has been discussed a little bit. So pancreatitis in simple terms means inflammation in the pancreas, and there are two types. So one is acute pancreatitis, where the pancreas was quite normal, and due to some insult like alcohol or whatever, suddenly there's inflammation in the pancreas, and then the patient presents with acute and severe abdominal pain requiring admission very often. And this generally resolves completely in most patients. And of course, there's chance that they can have some episodes of pancreatitis again and again. In some patients, because of chronic use of alcohol or various factors, there are certain things called as, earlier they were called as tropical pancreatitis. So there you get a lot of calcifications and permanent damage in the pancreas. So this leads to, like it was included earlier, exocrine deficiency or a malabsorption of all the food which you eat, especially fats. Then there are certain disorders which are seen in the later age group. These are pancreatic cancers. So these are very dangerous disorders which can present with abdominal pain and jaundice, generally seen in people above 50 years age. There are various treatments available for it, which we will not go into. And there's a new set of disorders now which we see because we do so many imaging tests. So they are called as cystic disorders of the pancreas, where the patient has gone, for example, for an ultrasound for some other reason, and the sonologist refers to you back saying that there's a lesion in the pancreas which is cystic. So these are called as cystic lesions in the pancreas. So there's a wide gamut of disorders which can affect the pancreas. pancreas, and each one, needless to say, has its different etiology of cause, its different cause, and different treatments which are offered.
So we just got to know that alcohol is one of the primary reasons that the pancreatic health is affected. How does it actually affect the function? Could you elaborate on that?
So alcohol is, like everybody knows, beyond the limit and with an addictive tendency. It's a dangerous thing for a lot of people who do both these things. So many organs are affected. One of them, of course, commonly known as liver, and the most other important organ is pancreas. So if you look at what happens because of alcohol to the pancreas, one thing is it can directly damage the cells in the pancreas, which are called the cells. And these cells actually contain all the digestive enzymes within themselves, and they're kind of in small sacs. And if you have this damage, they get released and you get sudden damage of all these cells and an acute pancreatitis. The second is there are certain cells in the pancreas and liver. These are called as stellate cells. So these cells are very peculiar in the sense that if you keep on taking alcohol, these stellate cells, they start laying down fibrous material. And once this happens over a period of years or decades, then there's permanent damage in the pancreas, which we call as chronic pancreatitis. And then if it persists, then it can, of course, lead to a lot of sequelae, which will be discussed by the other colleagues, I guess. So a wide range of disorders, various causes. Cause of each disorder is different. And alcohol is a very important factor, both for cancers as well as pancreatitis.
Thank you so much, Dr. Parimal. Going on to Dr. Piyush, what, according to you, leads to pancreatitis? Could you highlight a little about the prevalence and what is its impact on the disease and quality of life?
You see, this question has been answered in many ways by all previous speakers. Pancreatitis is inflammation of pancreas, and pancreatitis is broadly divided into two types: acute pancreatitis, chronic pancreatitis. And there is a third syndrome, acute on chronic pancreatitis, where you have recurrent episodes of inflammation, which may ultimately lead to chronic pancreatitis. Chronic pancreatitis refers to a state where there is a permanent functional and structural change in the pancreas, right? And acute pancreatitis is supposed to reverse completely. So acute pancreatitis would have different set of causes. Chronic pancreatitis would have different set of causes. And this has been mentioned earlier. And there is a growing belief that acute pancreatitis, severe acute pancreatitis, as Dr. Sanjay mentioned earlier, can lead ultimately to chronic pancreatitis. When there is severe acute pancreatitis, necrosis can lead to damage of pancreatic duct and lead to chronic pancreatitis. And various causes have already been highlighted: gallstone, alcohol, most common causes of acute pancreatitis. And then chronic pancreatitis, again, alcohol becomes the most common thing. Then other things like lipid, calcium-related disorders, hyperparathyroidism, and then genetic disorders and trauma in childhood. So these are the this is the entire gamut. And then when pancreas is affected, there are three main things which happen. In chronic pancreatitis, acute, that the patient is very sick, there can be different ranges of severity, and nearly 20% of patients have severe pancreatitis, which might have short-term mortality. Most of people recover. 80% would have mild to moderate pancreatitis, which would ultimately recover completely. In patients with severe pancreatitis, there would be this chances of dying in the acute phase of illness and various complications. In chronic pancreatitis, there arises the issue of this quality of health, quality of life issue, where you can have issues related to pain, which is the most important symptom. Chronic recurring pain would be there, which hampers the quality of life and may lead to some on some opioid analgesics and other things. And then these patients may develop diabetes, all maldigestion, which may lead to weakness and vitamin deficiencies and things like that. And other complications related to chronic pancreatitis, like biliary stricture, uncommonly tumors developing later on, and cysts developing. So these might also present as pain, weight loss. So these are the issues which arise in the natural history of chronic pancreatitis.
Okay. So Over the years, have you seen a rising trend of patients being diagnosed by chronic pancreatitis? And has that also come into younger age groups? Like earlier, it was probably diagnosed in the older age group. So is there any difference that you've seen over there? And what could be the causative factors?
See, epidemiologically, South India has been this thing that, as was mentioned by Dr. Parimal sir, that South India has this disease entity, or entire India, named as tropical pancreatitis. And in fact, this disease is now decreasing. The tropical pancreatitis is now decreasing. And as we have more and more diagnostic tests, various genetic factors which were not diagnosed earlier, and we have some tests like endo-ultrasound where microliths and all these things are picked up. So causes of pancreatitis are being picked up more commonly. Acute pancreatitis related to alcohol may reflect an increase in alcohol consumption in society by and large, but the prevalence as such is the same.
Okay.
South Indian population, there are Indian studies which show that this prevalence of tropical pancreatitis is quite high there.
Understood. Thank you so much, Dr. Piyush. Going on to Dr. Hariharan, could you tell us how do you predict the progression and the investigation in chronic pancreatitis?
We just were discussing about the etiology or the various causes and several other factors like symptoms and signs that are in chronic pancreatitis. Generally, when you talk about pancreatitis, it can be an acute inflammation of the pancreas, which is acute, or it can be recurrent acute, or it can be chronic pancreatitis. It's only the chronic pancreatitis which has got several stages. Like, you've got an early chronic pancreatitis, and then you have got first a latent pancreatitis, then you've got an early pancreatitis, then you've got a late pancreatitis, and you've got an advanced stage of chronic pancreatitis. So if you want to know how the pancreatitis progresses from one to the other, you really need some investigations. So regarding how the pancreatitis progresses, the best investigation to know is to really take a small piece of pancreatic under the microscope. But unfortunately, a pancreatic biopsy, one, is risky, and it is not a investigation which is safe enough for you to keep doing repeatedly going for pancreatic biopsy. So in order to understand what are the various stages of pancreatitis, you have to go in only for certain non-invasive and investigations which can easily be done by the patients. One of the tests involves is imaging the pancreas. You can check the pancreas by doing what is called as an CT scan, MRI, or there are ultrasounds attached to the end of endoscopes, which is called as an endoscopic ultrasound. You can use the endoscopic ultrasound also to find out the structural and morphological damage to the pancreas. So the way to diagnose a very latent pancreatitis, latent stage of chronic pancreatitis, that is absolutely very, very early stage of chronic pancreatitis, is by doing an endoscopic ultrasound. And there are special characteristics seen on this endoscopic ultrasound, which will tell you like some changes, minor parenchymal changes. Suppose the next stage will be early and later, then you can obviously pick it up on a CT scan where the pancreatic gland will show calcifications, the duct may be dilated, the pancreas gland itself may be shrunken, the duct may be filled with stones, the pancreatic gland may be calcified and may show irregular calcifications throughout the gland. So by doing an endoscopic ultrasound or by image. Next thing you can do to assess the stage of pancreatitis is by doing some tests. Like you can do the stool examination. There are some enzymes which are produced by the pancreas and then excreted off in the stools. So by quantifying that amount of enzyme in the stools, particularly there is one special test called fecal elastase. This is an enzyme. By quantifying the amount of elastase in the stool, one can say that if this is very, very early pancreatitis, or if it is quite normal, then it's very unlikely that the patient has got any functional abnormality. By quantifying the amount of fecal elastase, one can say how early or how late or how damaged the pancreas is. Apart from the elastase, there is also something called chymotrypsin, which can be used. Just when I said about the stages of chronic pancreatitis, this is more applicable to alcoholic chronic pancreatitis, but this can be loosely applied to all types of chronic pancreatitis in general.
My next question to you is, if diagnosed with pancreatic disorder, what are the dietary recommendations that you give that should be adhered to and for a patient to actually manage the problem?
See, there are two main issues with pancreatic function, which my earlier colleagues have alluded to. One is there is something called the pancreas does a digestive function. The pancreas also got an endocrine function, or what it does is that it produces certain chemical messengers like insulin, which is important for glucose control, which basically is that when that insulin doesn't work, you develop diabetes. So there are two different problems. Chronic pancreatitis is nothing but, or when there is a pancreatic damage, you lose two functions. You lose a digestive function, you lose the control of blood sugar. That is basically the patient developing diabetes. So when you look at dietary this thing, first you should know which stage the patient is in. If he is in a very, very, very early stage, so you have to understand if the pancreas has got a vast reserve. At least 90% of the gland should be completely destroyed for you to have a very poor maldigestion and steatopenia, which means the greasy stools. So there is enough pancreatic reserve. So in very, very early stages, the patient may not have any maldigestion, but may have minor symptoms. So depending upon the stage that the patient is in, if he is in very, very early stage, if you can pick out the factors like if he's been drinking alcohol, if he's smoking, you can avoid certain things, what is causing or damaging the pancreas, then that would be enough along with a normal diet. Suppose that pancreas has gone to a stage that the damage is extreme to the other extreme, where there is about more than 90% of the damage is already done, then there are possibility that he may have both. He may have diabetes because of his endocrine deficiency. He may have poor digestion because of the lack of enzymes, in which case you have to adjust the diet. The pancreas, although the pancreas digests the carbohydrates, the fats, and the proteins, the main thing is the fat. So the major important organ is in fat digestion because of its enzymes. Even the proteins, there are other enzymes, particularly in the stomach and in the intestine, which will help you to digest the protein. There may be good absorption of carbohydrate despite an advanced pancreatic damage. But then the protein, the main protein happens because of pancreatic juice. So when this lipase is completely gone from the pancreatic juice and it is not there, the patient develops severe protein maldigestion. So once you have protein maldigestion, you have to most of the pancreatic fellows with pancreatitis or pancreatic exocrine insufficiency are asked to restrict the proteins. Asked to restrict the fat. The main thing is that they should restrict the fat significantly. And the other thing is that they are asked to consume reasonable quantities of proteins. But carbohydrate, that is where it comes in, depending upon if the patient has got diabetes or no diabetes. Depending upon if he is a diabetic, then obviously he has to go on the carbohydrate should be according to his diabetic diet. So low fat, reasonable proteins, and carbohydrate according to the presence or absence of his diabetes. And apart from it, the chronic pancreatitis, because there is protein malabsorption and maldigestion, you have deficiencies of fat soluble vitamins like A, D, E, and K. So henceforth, they all have to be reasonably pushed in through alternative means to make sure that the patient does not have any vitamin deficiencies. Apart from it, because the patient experiences malabsorption and maldigestion, you should have to supplement him with certain micronutrients as well.
Okay. So, Dr. Sinha, my question to you is somewhat on the same lines. How important are the lifestyle changes according to you, like exercise, diet, sleep, in ensuring a good pancreatic health?
Common etiology of acute and chronic pancreatitis has been already mentioned. And as we understand, the commonest etiology remains alcohol, and other common etiologies are gallstone. So our preventive strategy will be centered mainly around these. So if we talk of alcohol, alcohol causes acute pancreatitis as well as chronic pancreatitis. There is difference because for chronic pancreatitis, it is regular chronic use of alcohol, which leads to chronic pancreatitis, and this has to be in significant doses. Different societies have talked of different doses, but unlike chronic pancreatitis, acute pancreatitis can be caused by even single social drink. So it is very important not only to avoid alcohol, avoid alcohol completely altogether. So don't touch principle should be followed if one has to escape the risk of pancreatitis. So acute pancreatitis, there is no dose response. So even single drink is dangerous. Whereas in chronic pancreatitis, chronic use, long-term use, more than 5 years, more than 10 years, and then threshold value more than 40 grams, 60 grams. So that causes chronic pancreatitis. So then the other issue is that not only that, alcohol also causes pancreatic cancer. So many people need to be aware that alcohol is a classified carcinogen in a dose of more than 1 drinks per day for females and more than more than 2 drinks for males. So not only pancreatitis, that also causes pancreatic cancer and several other cancers. So that should be important. Second is like gallstone is a very, very important cause of acute pancreatitis. It can only rarely can cause chronic pancreatitis, but risk for gallstone we all do understand that lack of exercise, obesity, high fat intake. So these are the factors which give rise to gallstone. So obviously we need to control, we need to modify our lifestyle in a manner that fat intake should be low. There should be exercise. There should not be obesity, particularly there should not be truncal obesity, and that will reduce the risk of gallstone and consequently the risk of acute pancreatitis. The most important point here, some people particularly in general population believe that bigger stones are more dangerous. Here there is paradoxical situation. The smaller the size of gallstone, the more the risk of acute pancreatitis. So if somebody finds that ultrasound is done, there are multiple small stones, and then thinks it is less risky and doesn't undergo cholecystectomy. So this myth should be refuted, should be clarified that these are more risky and possibly will need to undergo cholecystectomy or treatment for that, because those small stones tend to come into the common bile duct and cause acute pancreatitis. Another important cause of pancreatitis is raised serum triglyceride level. This is of two types. One is genetic, for which one cannot do much about that, but still the dietary intake of fat can be reduced, but that will have only limited impact. But other is acquired variety, that is pretty common. With lots of non-veg food, lots of fatty meal intake, the triglyceride tend to go up, and that will be a risk factor. So that also should be understood. Another entity which is coming up pretty fast now is like everybody is now aware of fatty liver. The same factors which cause fatty liver, they also cause fatty pancreas. So we should go for exercise, we should avoid fatty meals, we should maintain our ideal body weight, and those will also improve the health of pancreas. Then few things, particularly in slightly less developed societies like worm infestation, they are also an important cause of pancreatitis. So if anybody has history of passage of worm, it should be promptly treated, particularly in endemic area. In India, Jammu Kashmir happens to be particularly endemic area for roundworm-induced acute pancreatitis. The another entity which is emerging pretty fast is drug-induced pancreatitis. With more and more advancement of science, we have large number of drugs which can cause pancreatitis. It is very important to remember that if anybody has an episode of acute pancreatitis because of drugs, either suspected or proven, he should carry a clear-cut label on his medical record, and he should always mention that, okay, he had episode of pancreatitis related to drugs, because occurrence of one episode makes that particular drug contraindicated completely for whole life of that particular patient. So this should be very clearly understood by everybody and should be practiced.
These were probably all the questions that we had. One of the questions that is open to all is, how difficult do you find in diagnosing this pancreatic disorder? And do you think patients often come really late thinking that it is something else, or could be, which usually happens for the other diseases as well? Do you feel that patients really end up coming to you really late after the difficulty has really, extended to a large amount?
So I think if I may take this,
Sure.
what you said is very true. Yes, not in acute pancreatitis, of course, the patient has a lot of pain, so he'll come to you immediately. But especially in pancreatic malignancies, the pancreas is located very, retroperitoneally, as we call it. So it is behind, and the symptoms are pretty non-specific. So the patient will have some pain, which initially we may feel is not very specific. It could mimic acidity, and then an ultrasound may be done, and it may or may not show up the pancreas very well. And then a very high index of suspicion is required on part of the doctors to make a diagnosis with an early CT scan or something like that. Now, imaging, like it was alluded earlier, has tremendously advanced for pancreatic disorders. So you can choose one of those modalities as per the clinical picture. But like you rightly said, I think there are a lot of people who can present with early signs, and because there are certain difficulties in making a diagnosis of pancreatic disorders, there can be a little delay in making the diagnosis. So it's a very valid point, and I think with increasing awareness, like with these programs or all the CMUs which we do in conferences, hopefully this awareness will increase and we can have an early diagnosis of pancreatic disorders.
Particularly, can I just add, the thing is that particularly as Dr. Parimal has said, the pancreatic disorders, there are some, like the very, very early stages of chronic pancreatitis is very difficult to diagnose. As I said, latent chronic pancreatitis. When somebody has been consuming too much of alcohol, and if he comes with typical symptoms of abdominal pain and other things, we know he is developing some damage to his pancreas. We have no way of saying he is already on it, except there are very, very early changes. As I showed you, ultrasound probe attached to the end of a scope called an echo endoscope, which can be used to find out early changes. This is how we can tell the patient that he is ending up in damage, and we can stop him from taking alcohol and can stop the further progress of disease in such patients. Very latent chronic pancreatitis is difficult to diagnose. Of course, the other things, when it is acute pancreatitis, then anybody is going to be in the hospital, and we know it is easily diagnosed. Particularly when it is very, very late, when already all the damage is already done, then it is very, very easy to pick up these chronic pancreatitis. But as Dr. Parimal said, it is our suspicion first. Unless you have a suspicion, you can never pick up very, very early chronic pancreatitis. Or when you suspect that he's likely to have chronic pancreatitis based on the history and symptoms, you are not going to pick up early, very early or latent pancreatitis. It is difficult.
I will like to point out, make mention of 2 points. Acute pancreatitis is associated pain, so patients tend to come very early in the to the hospital or to the practitioner. It is very important to realize that ultrasound is not a good modality for diagnosis of acute pancreatitis. So many patients tend to go back thinking ultrasound is normal and then I don't have acute pancreatitis. So that myth should be burst. So if suspicion is reasonably high, we have to go to better modality. So that is point number 1. Point number 2, if somebody comes with chest pain, has a normal ECG, everybody knows that he has to go for the biomarkers like TROP-T, TROP-I or other enzymes. And then there is window. If somebody has come with 48-hour pain, then nobody will go for TROP-T, will go other biomarkers. Similarly, in acute pancreatitis, if patient comes say for with 30 minutes of pain, you do a mileage and it comes normal, or lipase and it comes normal, it is very important to realize that this has to be repeated after 6 or 12 hours. So one isolated single value doesn't rule out if it is outside window period. And the window period, one needs to know that within 6 hours or 12 hours of the onset of pain, it may be normal. So it has to be clearly followed. The algorithm has to be followed very clearly.
I think I need to make 2 points regarding the investigations in pancreatitis. See, the standard of care with investigation in chronic pancreatitis is CT scan. We know this. This is accepted by almost all the guidelines and all the societies. But CT scan has a sensitivity of 75%, suggesting that perhaps 1 out of 4 might miss on CT. Apart from CT, we have MRCP with MRI or US. US is operator dependent, and being a gastroenterologist, being a person performing US, I do agree that US is operator dependent, and most of the cases the diagnosis somehow what plays inside the mind of the operator or the gastroenterologist, that plays a significant role in the final diagnosis. Even whatever may be the modality, CT scan, MRCP or US, none of these are able to identify, as told by Dr. Parimal sir, the pancreatitis, chronic pancreatitis in the early stage. And perhaps the best investigation for chronic pancreatitis in the early stage is secretin stimulated MRCP, which is hardly available and not practiced anywhere in this country, as I believe, as the information I have. Regarding the point of symptomatic presentation, see, clinical or laboratory diagnosis of acute pancreatitis is easy. Most of the cases, we don't have any problem diagnosing acute pancreatitis. It is the chronic pancreatitis that is an important, and more important than that is pancreatic carcinoma, as told by Dr. Parimal sir. Particularly carcinoma of pancreas or cancer of pancreas occurring in the body, which might present, might not present as jaundice, as occurs with head of carcinoma pancreas. It might present a non-specific dyspeptic symptoms, which both the physician and the patient may neglect for a long period of time.
Yeah, Dr. Piyush, you wanted to add something?
You see, the diagnosis of acute pancreatitis is not a problem. As Dr. Sinha has pointed out, there might be timing issues and investigation. What do you choose? In a subset of patients, the challenge is to find out the cause of acute pancreatitis, and there you need to choose your investigations quite wisely. Things like triglyceride, calcium, if they are the cause of pancreatitis, they might be normal early in the course. So they need to be repeated maybe 2 weeks later when the inflammation has settled. And whenever you don't find any cause of acute pancreatitis, always do an endo ultrasound on follow-up so that you find out missed gallstones, microliths, and these are very important causes which can be treated very easily. The second challenge in chronic pancreatitis is to diagnose early chronic pancreatitis, as has been highlighted by everybody, that in early stages, when you do not have structural changes in the pancreas, then maybe an endo ultrasound or maybe a secretin MRCP might be important. The functional tests of pancreas, again, fecal elastase and those things do not pick up very late stages of chronic pancreatitis. The late stages of damage, they do pick up. Early stages, they do not pick up. And again, the reason of recurrent acute pancreatitis, with genetic tests being available, they need to be used judiciously, appropriately. There are many other findings like pancreas division. Whenever you come across a MRCP showing pancreas division, then it needs to be found out whether it is causative or it is just an incidental finding. So these are the challenges. And then certain new diseases, Dr. Parimal had earlier pointed out, cystic diseases of pancreas, they need to be followed up very clearly. Autoimmune pancreatitis is one thing which can present as acute pancreatitis, can mimic pancreatic cancer. So that needs to be kept in mind and investigated appropriately. So there is and with new tests, and especially endo ultrasound is a great help in many of these situations, needs to be used judiciously.
You talked about early pancreatic disease. Are there any symptoms that actually indicate, or the person can take a measure of going to the doctor?
Just as Dr. Parimal had pointed out, early pancreatitis might present just as dyspepsia, non-specific upper abdominal discomfort, bloating, maybe diarrhea. So all these things, when they're followed up algorithmically, then you might reach to a diagnosis of pancreatitis. And in an appropriate clinical setting, say the patient is taking significant amount of alcohol, or there are other risk factors of developing pancreatitis.
Okay, thank you so much, sir. My next question is, do you think pancreatic disorders are less spoken about as compared to other gastro disorders that we see?
I think, you see, there are difficulties in treating these pancreatic disorders. It is not that it is less spoken about or this thing. It's not being ignored or anything like that. It is just that the difficulty with treating this chronic pancreatitis when they come in pain and maldigestion, malabsorption, it's such an expensive disease as well. Somebody has chronic pancreatitis and he has to take replacement enzymes for life, and he has to take insulin for life. Think about the amount of economic impact on one's life. The pancreatic enzymes don't come cheap. They are extremely expensive. So it is not that they are ignored. They are being diagnosed. In fact, we have come to a stage where we can diagnose very, very early pancreatitis with so much of lovely investigations we have got these days. We are doing more to those pancreatic things, but unfortunately, it continues to be a problem with the treatment, because once it reaches an advanced stage, particularly with pain, and even for liver, you have a liver transplant. For pancreas, we are trying pancreatic transplant. They are, they haven't been much of a success, but it's being, tried. But they try there are patients, because of extreme pain, have undergone complete pancreatic removal, which results in such a bad quality of life for them with brittle diabetes, which means that their blood sugars are all over the place. And, not nice to have chronic pancreatitis or, pancreatic insufficiency. That's what I would say. It's not being ignored. It is, nobody likes to talk about it because it's so bad.
A concept which is coming up is screening for pancreatic cancer. So a lot of times this was not very existent few years back, but now you have a patient who is a diabetic, who is obese, who has alcohol and smoking history, and who has a family history of pancreatitis. So there are certain categories where you can screen these patients for early pancreatic cancer, because this disease is one of the most treacherous and bad disease to have for any patient, and cure chances are very low. So there have been efforts of late to try and screen patients for pancreatic cancer, and there has been some success, and some categories of patients have been identified where it can be beneficial, much like you screen for colonic cancer with a colonoscopy. Any comments from the panelists are welcome on this.
You see, the difficulty with pancreas is that, as was mentioned earlier, it is an organ which is located in retroperitoneum. Routine ultrasound might not give you a good imaging, and the initial symptoms might be just like non-specific symptoms, and functional tests are not there. And you talked about awareness. You see, usually acute pancreatitis comes like a bolt from blue. The person was quite well one day back and suddenly developed severe pain abdomen. And as Dr. Sinha mentioned earlier, small gallstones and this thing, we really need to look, recalibrate our practice, that even if patients who are not very symptomatic are found to have multiple small stones, given the current level of safety, today the recommendation is that if there is no pain, do not operate upon the gallstones. But for multiple small gallstones, that might be a different thing. I would like to have comments from Dr. Sinha and Dr. Parimal. What is their practice in these situations? I mean, you cannot give us advice to the patient that you forget about this stone and get operated only when you have pain, because in multiple small stones, the first episode might present as acute pancreatitis. So that is one very catch where adequate information and scientific recommendation is not there, I would say. Dr. Sinha sir, Dr. Parimal sir.
I fully agree with you. I think you should consider surgery for these patients, especially if they are traveling very frequently, though they don't have access to quick medical care. But by and large, I think best thing maybe to consider surgery and remove the gallbladder. Laparoscopy, which of course has now become so safe that we don't really need to think about side effects of the surgery.
No, there is always a role for a prophylactic gallbladder removal where there are tiny stones. That everyone agrees. But it is all in selected subjects most of the gastroenterologists would agree that in selected patients where even if they don't have pain, when there is a risk, because as pancreatitis, chronic pancreatitis, you get damage of gland. Acute pancreatitis is sometimes can be fatal. So if there is chances that the patient is too far away from a place where he can have medical help or too tiny stones, something in a selected group, yes, we can, to avoid pancreatitis, can go for prophylactic surgery. But otherwise, the best way to prevent pancreatitis is to avoid the risk factors like alcohol. And even if somebody has got chronic pancreatitis, there is always a chance any patient with chronic pancreatitis is going to develop pancreatic cancer. So adding smoking to their lifestyle is the worst thing that they could do. Avoiding smoking, and it definitely increases the risk of pancreatic cancer. Even in normal people, it increases the chance of developing pancreatic cancer. So lifestyle intervention. Stop alcohol, stop smoking, be careful with your diet, good lifestyle. Certainly may keep that such small, tiny organ, which is placed well behind. He can be a very troublesome bloke, but best is to keep him happy all the time so that you can have a good life.
Thank you so much, Dr. Hariharan. I was coming to your messages for our public, but you already touched upon that. Would the other doctors also like to give a takeaway message for our listeners?
We should spread this message that people should stop taking alcohol, because alcohol is strongly related to both acute chronic pancreatitis, and chronic pancreatitis may land up in pancreatic cancer. And this is further compounded by the effect of smoking. So avoidance of alcohol, avoidance of smoking. And once it's a diagnosed case of chronic pancreatitis, there is a need for lifelong treatment, lifelong follow-up. Treatment is costly, investigations are costly, and there is a need for lifelong follow-up. And in spite of best efforts from the physicians or gastroenterologist side, there may be newer complications developing in the course of chronic pancreatitis. And there is a urgent need to recognize the existence of pancreatic cancer for two reasons. Number one, the outcome, what we say 5 years expected survival, the outcome of pancreatic cancer is much worse than most of the cancer related to gastrointestinal system. It's worse than colonic cancer. It's worse than most of the cases of gastric cancer what we face nowadays. And as per WHO estimates, by 2030, pancreatic cancer is going to be the third common cause of cancer-related death. So this is nothing rare. This is a burning issue. This is going to be more common, and we're going to face more and more cases of pancreatic cancer. The first step for this is recognition of this entity, that pancreatic cancer is there, and we need to recognize them at an early stage.
Dr. Piyush, your message.
The messages are already very loud and clear. As far as alcohol goes, that is a very complex issue, but definitely avoid binge drinking. Once you have been diagnosed with pancreatitis, chronic pancreatitis, then certainly no alcohol. And as far as if you have chronic pancreatitis, then a lifelong follow-up is required. So you need to be very careful with what is, and there can be some complications. This prefix chronic is, whenever there is this is there with any entity, that means that there has to be some amount of, this organ cannot come back to normal. So you have to understand this and follow this up. And pancreatic cancer, obviously, that is can develop with chronic pancreatitis, without chronic pancreatitis. So this is a very important cancer, which is challenging to pick up early in the course. So we need to have better diagnostic tools. We need to have better search, markers which can pick up early pancreatic cancer.
I will like to talk about the risk of recurrence of acute pancreatitis. Because if somebody has developed acute pancreatitis related to alcohol, there is very, very high probability that with continued use, he or she is going to develop again. So it need to be explained clearly that if you continue to take alcohol, there will be recurrence, and it is question of only time that you will have recurrent disease. And as I mentioned earlier, that it should be clearly mentioned, the risk of acute pancreatitis is not dependent on dose. Even single drink or even 2 drink on a social event, it can lead to acute pancreatitis. That is point number 1. The point number 2, with gallstone acute pancreatitis, sometimes patient feels that okay, he can have treatment for gallstone, cholecystectomy, lap chole or other things. at the his convenient time, which may be 6 months, 1 year, or even 2 years delayed. It has to be re-emphasized very clearly that risk is pretty high. Risk of recurrent acute pancreatitis can be high, and the first episode was mild. The second may not be mild. It may be moderate, it may be severe, and it can even be life-threatening. So the earlier done the better. As early as episode of acute pancreatitis, when the patient is fit, it should be done, mostly in the same admission, and if not, then as soon as the patient is fit, in case of severe acute pancreatitis. So early cholecystectomy is important, and complete cessation of alcohol intake is absolutely mandatory to prevent rectal disease.
Dr. Parimal, your message.
Yeah, I'll add a little shade of optimism to all this discussion from a gastroenterologist and our friend colleagues' point of view, that the treatment of pancreatitis and these disorders and diagnosis has changed tremendously over the last decade or so. And there are a lot of patients who used to have major operations for these disorders, and now they can be treated endoscopically without a single scar on their abdomen. And on a lighter note, it was said in the past that God has made the pancreas behind so that surgeons meddle with it. And this has really come true today in a way, because a lot of these disorders which were in the domain of surgeons have now come into the domain of gastroenterologists. And people who have these disorders, which are very troublesome, they can now reasonably well managed with better understanding with all our expert colleagues. And we can very good cure and relief to a lot of these patients. There are challenges, but it may be interesting to note that this year itself, we had the first pancreatic club meeting, and some of the esteemed panelists were office bearers for this. And so there was a lot of attendance by gastroenterologists. And so I think not only patients amongst the gastroenterologists, also this is a field which is rapidly changing, generating interest, and hopefully I think we should keep on doing better for our patients as days go by.
Dr. Avinash, your message.
Yeah, so I think all the points are very well covered by my senior colleagues. But one thing is, eat small, exercise regularly. Please be on a regular follow-up with your gastroenterologist. So stay healthy.
Thank you so much, all the doctors. It was really a very interesting discussion. And with this, we come to the end of this discussion with the key takeaways on how to keep the right approach to protect your pancreas. Thank you so much for sharing such meaningful insights and takeaway messages. Appreciate all the experts for joining us today, and a big thank you to all the attendees for tuning in.
Thank you very much. Thanks.
Thank you so much, everyone.